towards Nepal. I want to thank the Vascular Society of Nepal for the ability to come and talk. And as Robin discussed, hopefully some of this will just be good education for all of the medical professionals on the line. And it will be talking about advanced endovascular interventions in peripheral artery disease and indications, as well as some good adjuncts to open surgery, and then indications in which this is a good bailout therapy as well. So should be well-rounded for everybody on the meeting today, and we'll go ahead and get started with it. So I have no relevant disclosures to talk about. When you look at the background of what we're talking about, when we talk about arterial disease, really the main risk, it's not cancer progression, it's not metastatic disease, it's not worsening of diabetes, it's really risk of limb loss and the major disability that comes with that if not treated and addressed and diagnosed early and appropriately. Even here in taking call as a vascular surgeon in the US, we find this all the time, is there's a big difference between providers' ability to diagnose, even the difference between chronic limb ischemia and acute limb ischemia. So we'll spend just a couple minutes on that. And the big issues with indications for procedural intervention here. When a patient comes in with critical limb ischemia, severe rest pain, tissue loss, their risk of major amputation is significantly increased over those patients that come in with claudication. And we need to be able to isolate claudicants from those with critical limb ischemia before we even start thinking about intervention. If someone comes in and they're a 3-4 block claudicant, they have ABIs of 0.6, 0.7, really only about 1 to 3% of those patients will go on to major amputation over a 5-year period. If you can get them to stop smoking, that'll be relatively stable. If they continue smoking, then about 2 to 3% of those patients who aren't progressing towards major amputation will move into that category with continued habitual smoking. But for the most part, this is a small number of claudicants that cross over into the major amputation category. As I was talking about, the later end of this talk, we'll be really looking at technical adjuncts and approaches for different clinical environments and indications for some of the endovascular treatments we have available these days. So what is this not? I mean this so sincerely when I think about Prem and Robin and Satish and all of our partners in Nepal. I wish I was there today. We were on the launching pad and had to pull out of a trip just a few weeks before, and it's all due to this, COVID and the risks that come with it. This is a severely ill COVID positive patient that was treating just a few months ago. And this is not what we're talking about today. Symptomatic COVID patients coming in with in situ thrombosis. We understand there's some severe inflammatory changes and essentially a SIRS response that presents with acute limb ischemia. Very different pathophysiology than what we're going to discuss as far as lower extremity arterial disease. What are we trying to avoid? It's one thing, and it's one thing only: major amputation. This is the main morbidity that comes with this, significantly more pronounced in older patients with advanced peripheral neuropathy, patients that have instability with balance and gait to start. And this can be a significant change to functional status if we have this as the end result. For patients who have acute limb ischemia with reperfusion, it can certainly be more serious if you have misdiagnosis of rhabdomyolysis ending in multi-organ failure and even death around successful revascularization. The most important slides here are indications to intervene. Why should we do anything in the first place? So with chronic critical limb ischemia under the Rutherford classification, as you can see, categories 1, 2, and 0 really are the claudicant range. These are patients who have issues with treadmills. You can diagnose it with treadmills. You can diagnose it with resting ABIs and review of symptoms. But as we get down into category 3, 4, 5, and 6, these are the people that enter the limb loss category. They can't even complete a treadmill. They have decreased ankle pressures, and then it becomes a clinical diagnosis. Do they have tissue loss? Is it in the distribution of what we'd expect a critical limb ischemia to present as? And then ischemic rest pain really as dorsal foot pain that is positional at night. It's not plantar fasciitis. It's not heel pain. It's not arch instability. It is dorsal foot pain between the first and second interspace that's persistent and happens every time positionally at night, very reproducible. Then we look at acute limb ischemia, much easier classification here. And as you can tell, patients who come in category 1 or 2A have maybe minor sensory losses. Those patients can be bridged on a heparin drip and treated under a more elective setting or pseudo-elective setting. As we get down to category 2B and 3, these are the patients who really need intervention, and they need it on a more timely matter. What's the difference here? So if we look at this classification, really it's when you start to see some paralysis, when you start to see motor dysfunction. And by the time you're getting to 3, where you have complete loss of motor function and sensory, it's irreversible. And then your intervention doesn't become arterial, it becomes a primary amputation. So the surgical history is wide. Robin knows this from past presentations. I love the history of this, but we're about 200 years out from the folks that started doing a lot of early arterial intervention, but we've moved a long ways. So here's acute limb ischemia, a great picture of someone who comes in mottled, significant skin changes. You can see the picture on the left here shows that sort of very reticular capillary appearance to the feet, no capillary refill, pulseless, cold mottling, loss of sensory and motor function to some extent within the category of the Rutherford classification. As Dr. Udom discussed, likely etiologies, aortic or cardiac embolus, acute on chronic disease, or failure of prior intervention, so acute stent occlusion or bypass occlusion. Really what we're talking about when we're talking about elective intervention, those that don't have to be done within the golden hour, are the patients with chronic limb ischemia. And this is really what we're seeing. This is the difference. So dry gangrene along distal capillary areas. So digits, toes, dorsal foot. They may have dependent rubor, but modeling is not present. They don't have motor dysfunction. The motor function is intact. Sensory function should be intact unless they have some underlying diabetic neuropathy. They present with ulcers, rest pain, and non-healing wounds. So how does endovascular therapy change the ability of surgeons to provide limb salvage in addition to or separate from open surgery? I just want to present a couple cases. So here's an easy one. We'll start off. Interventions after open surgery. Here we have basic femoral access with a 6 French arterial sheath. You can see neointimal hyperplasia after years of a patent bypass. And this was found, as Dr. Robin discussed, duplex surveillance, very important. It's amazing how a couple $100 duplex ultrasound can do more in the right hands than a multi-million-dollar MRI and CT scans. This patient had velocities above 400 centimeters a second. The pre-intervention picture is on the left, the post-intervention after drug-coating balloon, a cutting balloon angioplasty and drug-coated balloon angioplasty is seen here on the right. Really good resolution of the stenosis, and it was seen both on angiography and confirmed on duplex. What are we using? Well, cutting balloons, especially for neointimal hyperplasia, drug-coated balloon angioplasty. Here you can see a Lutonix balloon in the middle, and then primary stenting. What about another adjunct? So here's interventions after open surgery. This is a 52-year-old who I completed an above-knee popliteal to dorsalis pedis bypass. Here you can see the picture on the left shows the dorsalis pedis. This is the foot view here. The patient had significant distal anastomotic stenosis. Those had velocities above 500. I treated the patient with a 2.5 millimeter drug-eluting coronary stent. He is 7 years out from that procedure, has never required a reintervention. And as you can tell here in our imaging, I did give about 200 micrograms of nitroglycerin during the procedure to confirm that we had maximal vasodilation for our completion shots and that we weren't hiding any thrombosis or dissection after the intervention. And he actually has really good pedal runoff. Once again, an adjunct to open surgery. This is from about 6 months ago, a 39-year-old who was sent to me. He had a popliteal artery dissection. He was doing downhill biking as a part of a sport. and had a posterior knee dislocation that was missed. He had tibial thromboembolism from this and required a distal fibulectomy with a perineal target. Here you can see the green arrow is on the perineal artery, and then our cut fibula is here. This is further down towards the foot. So here we are finished. I'm completing an angiogram at the end of the case. Very nice conduit. This is his cephalic vein because he had no vein in his leg. And unfortunately, we have really no runoff here. And the question is this vasospasm or is this something technical? And it was actually a clamp injury right at the level of his perineal below where his fibula was transected. Once again, the only difference between this angiography and this is intraarterial nitric. So this is a combined approach, and this is to obtain through wire access. So being able to get one wire from the level of our pedal access down here. So this is a needle with a 4 French micropuncture catheter in his dorsalis pedis right about here on his foot. And here's our wire going retrograde up the occluded anterior tibial artery. Here's our wire coming from the groin, which is in the perineal artery. And here we are doing subintimal AT recanalization, as Dr. Udom was discussing. This is our wire coming up from the foot. We have a nice subintimal loop of wire here with an 014 wire. We're maintaining access in our perineal and our below knee popliteal artery. And then the next key step after this recanalization is to traverse the occlusion, get back into a true lumen, our artery above the level of the occlusion, and then make sure that you've intervened on this area of subintimal plane so that it isn't a long-lasting stenosis that'll limit your intervention. So here's our subintimal plane. We've been able to snare our wire in a technique very similar to what's shown here in the center picture. So we brought our snare down from our femoral sheath, snared it in the below knee popliteal artery, and then we have nice through wire access that goes all the way from the foot all the way up to the groin sheath, gives you a good stability to your devices. And then we were able to stent across our subintimal reentry stenosis. So this looks pretty junky after our recanalization. It would never last. We've defined our reentry points here and made sure we've treated them completely so that we have runoff to the foot. So with the pedal outflow, we have now this nice runoff. And this patient has had patency for the last 3 years. This is essentially 3 years old. He's never required reintervention. He has this nice dorsalis pedis for his target. One of the things that I do during this is once I have through wire access going from the foot all the way towards the groin sheath, you have clamps on either side that you're then working through. So you have a body floss technique. It gives a really nice rail to be able to get balloons and catheters and stents in the proper positioning without losing wire access. So then we safely close the pedal access with a nominal balloon inflation. Here you can tell this is us bringing our balloon into position from the groin sheath. Here's a little bit of some bleeding out, which would ultimately be a pseudoaneurysm at the level of our pedal access. But we do a nominal balloon inflation for a few minutes, reverse our heparin, and this normally is not a problem. So what about reentry devices? So we talked about a really simple technique to get a wire loop going, recanalize and get a subintimal plane, and then snare your wire so you have through wire or body floss access. Well, reentry devices, and this is just one of the multiple devices available. This is the Outback device. It's something that we use, but certainly there are many devices that do this. It maintains your subintimal wire here, so you can see our device getting into position. You use a combination of some 90-degree orthogonal views to make sure that once your needle is deployed, it's going towards the true lumen that you want to enter, and then you're able to get an 014 wire then across and re-entered into the true lumen of the artery. A very A useful device and another adjunct, a little trick that we use is we'll do a balloon inflation from the other side, put our needle directly into the balloon, wire into the balloon, and then pull our wire through. This can be done with smaller arterial lumens, sometimes with pedal or dorsalis pedis, or sorry, popliteal recanalization. So what about reperfusion? Never forget, after you've done all the work and you've recanalized these people or done a really nice peripheral intervention, there are costs. You can have conversion of dry gangrene to wet gangrene, warning urgent foot debridement so you don't lose the foot, not due to ischemia, but actually due to infection. Compartment syndrome in acute limb ischemia, revascularization. Edema management, if someone's really been chronically ischemic, they can have significant edema for up to a year. That has to be managed for wound healing. And then medication and dual antiplatelet compliance. Don't be fooled. This may look intervenable, but it's really not. This is leukocytoclastic vasculitis, a patient from years ago I took care of. We're giving him steroids, NSAIDs, colchicine, medical treatments and wound care, time to heal, and then amputation if needed. But there's really no role for arterial intervention here. So this is not a primary arterial pathology. And then pitfalls. Anything we put in can get affected. Here you can see an infected covered stent. This is after I've removed it, about 15 centimeters of a Viabond stent. Here you can see the green tinge discoloration of the stent. This was a pseudomonal infection with primary closure of the below knee popliteal artery and reconstruction here on the right. And the last couple of slides here, obviously, if you've done a successful revascularization, but there's been significant ischemia, don't forget the fasciotomies, especially if somebody's had a bear hugger on, or you've had warmth on the leg, or you've had a prolonged case. Go ahead, do your fasciotomies. Here's a lateral one with the anterior and lateral compartments opened around the anterior muscular septum, and you can see that anterior muscular septum right there. And here's our medial soleal release here to get down to the superficial and deep compartments. And ultimately, you can have limb salvage and a nice peripheral intervention. Thank you very much, Dr. Robin and the Vascular Society of Nepal for being able to present today. What a great partnership. We all wish we were there with you, but thank you for the invitation to talk.
Yes, thank you, Dr. Mike, for this wonderful presentation, and so many new things we could see and learn from today's presentation. We wish we could learn even more in future as well. So we have completed with the 3 presentations. So I would like to open the floor for some time for discussion. So if there are any queries, I would like to request participants to mention in the chat. Yeah.
I would like to ask Dean.
Okay, Dr. Sandeep.
Yeah, sorry, Dr. Michael. So Dr. Michael, are you doing DVA, deep vein arterialization for no option CTLI?
So, you know, we are, we've not had really great interval short-term success with deep venous arterialization. We've had a few patients here that we've used them, but we've really had more extensive revascularization with Safari, kind of what we were discussing here, and higher risk open interventions than deep venous arterialization.
Yeah, it's new. Thank you.
Yes.
So any other queries? Because we can just ask the questions right now. So any other queries? So I'd like to take one opportunity to welcome Dr. Anton also. I could see him also in the list. So welcome, Dr. Anton, from all the way from Holland. So I have a small question for Dr. Mike. So when you do like a popliteal recanalization, you showed some picture of doing from the both ends. I have a small query, how difficult it is cannulation on the distal part, on the distal.
Yeah, Robin, so that's a great question. And there's a question from Satish here about what doses of nitro to use as well too. You know, when we're doing our pedal access, Robin, and this is obviously something that if you do a lot of ultrasound guided access, which everybody does in Nepal, this is not a hard technique to get down. We used to think it was heresy. When I was in fellowship around 2009 or so, that you would access your vessel, your dorsalis pedis, your posterior tibial, and you would ultimately lose a target if it failed. So you'd take away all the open revascularization options, you'd trash the artery. But if you have good technique and you just make sure that you're doing Selgener technique, you're not dissecting your target where you're accessing. It really is a nice technique. I've tried for hours sometimes to recanalize an artery antegrade, so down the leg. And then once you get in pedal access and your wire just goes easily retrograde from a pedal access, I don't quite understand the technical components of why that's so different, whether it's just a fibrous cap or there's something with the pathology of the occlusion. But for whatever reason, a multi-hour antegrade attempted recanalization can turn into a 5-minute retrograde recanalization. You just got to make sure that you don't muck up the artery you're targeting. You treat your reentry flap really well. And at the end of the case, you can close your pedal access. So perineal obviously is harder here to do, but dorsalis pedis and post-tib is normally what we're trying.
Yeah, thank you. So also we have, as you mentioned, Dr. Satish has asked about the dose of nitroglycerin for arterial procedures and how long before should we provide the drugs?
Yeah, so Robin, I normally don't give nitroglycerin for venous procedures. A lot of times what I'll do is I'll just wait on table. So if you have a really significant vasospasm after like a central venous case where you've done a significant angioplasty, I normally won't give nitro. I haven't seen great results with that. I'll just give a little time on the table and repeat venography, 5 or 10 minutes after. Just keep your access, keep your wire there, and see what resolution you get. I really see it more with arterial disease for the impact of nitro.
Yes, and I have a small, I would like to request Dr. Uttam to share something about new hybrid OT, which is about to be complete in Monmouth Hospital. So I'd like to request Dr. Uttam to mention a little bit about what are the new vascular interventions we are planning.
So actually, Monmouth Center started only in 2009. That means around 12 years back, we have started the center. And we have started in the vascular surgery in 2013 with the TVAR as the first procedure. Now we have been doing regularly EVAR, TVAR, and intervention for the peripheral arteries, but in a small number. So let me take time that we are going to do an international conference, and our colleagues like Mike, Florian, Dean, Yanto, Ghost, I think they could help. And after a couple of months, maybe 4 months from now, around June 10, 11, we have decided to do the international conference, really targeting on the intervention vascular surgery. So we have been dealing with, and the cardiovascular, the hybrid operating theater will be starting maybe within 3 months' time. So it's in the progress. Now they will complete the thing within 2 months' time. So maybe after 3 months, we'll be heading towards doing procedures in our hybrid operating theater, and that will be the first hybrid cardiovascular hybrid operating theater in the country.
Yes, thank you, Dr. Uttam. So any comments by Dr. Dean?
Yes, I have a question for Mike. Mike, when you're doing the retrograde and you go subintimal back into the true lumen and you're angioplasting those, my assumption is most times you're putting in a stent then. Is that true, or you're just doing prolonged insufflation with your balloons?
Dean, that's a great question. We were doing a lot of primary stenting when we started doing this technique. We've tried to move away from that, but it really depends on the caliber of the vessel. I mean, if you're kind of re-entering in a pretty small caliber vessel, most of us have a pretty small margin of error here, where if you're leaving a dissection flap, you're going to have an issue. So you just need to make sure whatever the intervention is that's fully resolved, and more importantly, is that's really well imaged. So get the oblique that's going to show that. Take multiple views. Don't just do one picture that's going to look good in a conference like this. Get multiple views so that you don't have any flow limiting lesions, because I think the biggest downfall to this, especially when people start doing it, is that they don't treat their reentry. And so it looks good in an angio, but then you go back a couple days later and you go, boy, well, there's a flap there. I didn't treat my reentry where I thought it was. And that's why you have an early occlusion.
Yeah. Yes, thank you.
I guess my next question is you know, not everybody has stents. So, I mean, for example, Robin may have the balloon, but he may not have all the stents. So how often do you think you're placing a stent as opposed to just ballooning and working with prolonged insufflation? You know,
yeah.
It's a bit risky if you don't have a stent for backup.
Yeah, Dean, completely. I think, everyone thinks that a stent will resolve everything, and stents do a couple things. They're good at kind of resolving intimal flaps. They can give a little buttress to work, but they won't work in highly calcified lesions, right? So people think, they'll put a stent in this really calcified lesion, resolve it, that stent will occlude. And you're right, if you are trying angioplasty, but you don't have a bailout of a stent available, that can be a risky maneuver. The amount of times we're stenting, Dean, even after maybe a long nominal inflation drug coated balloon angioplasty or something in this area, is probably still a good majority of the time.
Yes, thank you, Dr. Mike, and thank you, Dr. Dean. So any more comments? Any comments by Dr. Florian?
Not really. I mean, the pictures are definitely thrilling, Mike. It looks great, even though I'm not totally convinced. You say it's pretty easy to cannulate or punctate the dorsalis pedis. I think, yeah, that should not be a problem if it's ultrasonographic steered. But the question remains, I mean, I recall the picture, and I think there was actually a pretty good fibular artery. Is that right? Or did I get that wrong? And usually I think one vessel is actually enough for the perfusion of the foot. So in that case, it looks great afterwards, no question. And as a bailout, yeah, I think would be an option, but I think it looks easier than it actually is. Is that true?
Yeah, and Florian, that's a great, we're doing the majority of these by far. I mean, greater than 90% are for people that have no inline flow to their foot at all. This patient was one of those rare cases where, I never like to use this term of angiosomes, because I think it really justifies people over intervening and doing the wrong things and trying to get 3 vessel runoff to the foot when all they need is one good one. This is a patient actually had a really significant toe and dorsal foot wound. And we just could not get it. He had toe pressures of less than 20. And you can tell the anterior division of that perineal is really non-existent. So yeah, he's reconstituting a DP, but had really poor perfusion to the foot that was ischemic in nature. So this was one of, kind of our earlier cases where it adds additional perfusion to the foot with a poor perineal, right? We all know it's the weakest to help with limb salvage of the 3 tibials. But you're right, the access, you have to be willing to spend some time, and we've certainly, I've been there for, you're sitting there 10, 15 minutes in, and you're trying to hit a dorsalis pedis that just keeps rolling around you or is so calcified, you're looking for a window to get in. So it can be certainly a good technique to a failed antegrade recanalization, but it takes effort, and it takes some experience with it for sure.
Thank you.
I think what Florian and you is trying to say, and also what you were trying to say early on in your talk or the beginning of your talk, the indications for doing these procedures is limb salvage. It's not the presence of an occlusion. I mean, just because you have an occluded artery doesn't mean you need to do anything about it. What you're trying to do is save the limb. And so Florian's question's a good one, and you answered it appropriately. In other words, if you did nothing, he was going to lose his foot. So, That's a point we try to make over and over. It's really about saving the limb or saving whatever. I mean, it's not just the presence of a lesion.
Well, it's exactly, yeah, and exactly that's, and Mike, you said, so also the angiosome concept has not been really proved. But in that special case, it might have been the special effect of this one vessel. So, I mean, it's definitely no criticism. It's just, yeah, it's re-questioning. But I think you answered it definitely properly. Thank you.
Well, Florian, you know, I just, you know, go back to Dean's point too, is it all relates to your response with physiologic testing, right? I mean, if you have toe pressures that are horrible, you clearly have ischemic wounds. For most people, a good tibial single vessel runoff is going to be enough. But once you start talking about an incomplete plantar arch like this patient had, a poor pedal collateralization, but I completely, you can make angiography pictures look great all day, and if you haven't changed anything with their physiologic pressures at their foot, you're in trouble. You're still talking about limb salvage or unnecessary procedures.
Was that a commentary? Or?
Yeah, thank you very much. So is there any more comments in the chat? I don't think. So shall we proceed to the second half of the first, this peripheral arterial disease session? So, so continuing with the presentation, I would like to introduce Dr. Santanu Kumar Ghosh. So he will be presenting about surgical management of peripheral arterial disease. So Dr. Santanu Kumar Ghosh is a vascular surgeon from Bangladesh. He did his MSc from Bangabandhu Sheikh Mujib Medical University and joined a vascular surgery department at National Institute of Cardiovascular Disease, Dhaka. And he is currently working as assistant professor in the same institution. And he has experience of doing more than 1,000 cases of emergency vascular trauma. And Dr. Ghosh is a secretary for international affairs of Bangladesh Vascular Society, or BVS. And he's also treasurer of SARC Society of Vascular Surgery and chairman of Bangladesh chapter of IUA Youth, member of BSI, VAI, IUA, UIP, ESVS, and SODAS. So I'd like to take this opportunity to welcome Dr. Santanu Kumar Ghosh. So Dr.
Robin, can you hear me?
Yes, I can hear you. So I'll show the slides and I'll change the slides for you. Okay.
Okay. So first of all, I would like to congratulate all the staffs of Dhulikhel Hospital for successful achieving 25 years. And I'd like to thank Dr. Robin, then my friend Dr. Sandeep for inviting me to this conference. So today, my topic is surgical management of peripheral arterial disease. So already we have learned about the basic things of the peripheral arterial disease that we usually get every time. So next slide, please. So next slide. So we basically use the inter-society consensus for the management of peripheral arterial disease, that is also called TASC, for the classification and management protocols of peripheral arterial disease. So it has been divided into two parts. It was first introduced in 2000, and then again it was modified on 2007. So it has two parts, the aortoiliac disease and the femoropopliteal disease. The previous slide, please, Dr. Robin. Previous slide. Yeah. So in task classification, there are 4 types, type A, B, C, and D. In type A lesions, this is called, you can see in the picture, that unilateral or bilateral CIS stenosis, unilateral or bilateral single short segment stenosis of EIA. less than 3 centimeter. This categorized in task A. For task B, there is short segment less than 3 centimeter stenosis in the infrarenal aorta, unilateral CIA occlusion, or single or multiple stenosis totaling 3 to 10 centimeter. In task C lesions, there are bilateral CIA occlusions, bilateral external iliac occlusions, 3 to 10 centimeter long segment, but not extending into CFA. Unilateral common external iliac stenosis extending into common femoral. This is task C. In task D lesions, this is almost to get infrarenal aorta iliac occlusion, diffuse disease involving the aorta and the both iliac arteries, diffuse multiple stenosis involve the unilateral common iliac, external iliac, and common femoral arteries. Maybe unilateral occlusions of both CIA and EIA, maybe bilateral EIA occlusions, or iliac stenosis in patients with abdominal aortic aneurysm not amenable to endograft placement. So these are the aortoiliac disease classifications of task A, B, C, and D. In femoropopliteal disease, type lesions include single stenosis of less than 10 centimeter in length or single occlusion of less than 5 centimeter in length. In type B lesion, there are multiple lesions. It may be stenosis or occlusions, each less than 5 centimeter, single stenosis or occlusions more than 15 centimeter, not involving the infrageniculate popliteal artery, single or multiple lesions in the absence of continuous tibial vessels to improve inflow for a distal bypass. In type C lesion, there are multiple stenosis or occlusions totaling more than 15 centimeter with or without heavy calcification. Recurrent stenosis or occlusions that need treatment after 2 endovascular interventions. In type D lesion, chronic total occlusion of CFA or SFA more than 20 centimeter involving the popliteal artery, and chronic total occlusion of peripheral artery and proximal trifurcation vessels. So these are the femoropopliteal disease. Next slide, please. Robin. Yeah. So what are the treatment options? For aortoiliac, the type A and type B lesions are commonly addressed by endovascular treatment. And for type C, surgical treatment is most often be used, but the insufficient evidence for recommendation. Type D is surgical treatment of choice. There are another guideline, that is NICE guideline for peripheral arterial disease, that is National Institute for Health and Care Excellence from UK. It was introduced in 2012 and again modified in 2020. So it includes modification of risk factors and secondary prevention of CVS risk, including smoking cessation, diet, weight management, exercise, lipid modification, management of diabetes, high blood pressure, antiplatelet therapy, etc. Next. How we diagnose this? We do diagnosis by assessment of symptoms like claudication, breast pain, ulcer, pulses, ankle brachial pressure, duplex ultrasound, and angiogram may include conventional angiogram or CTA or MRA. Next. So this is the procedure of ankle brachial pressure index. And next. Next, please. Here we can see the 3 modalities of angiogram on the left of the right of the screen, that is the conventional angiogram, and then in the middle, computed tomography angiogram, and on the right, that is MRI angiogram. Next. So how we manage intermittent claudication, that is supervised exercise program, 2 hours of supervised exercise a week for a 3-month period, encouraging people to exercise to a point of maximal pain. Next. Then angioplasty and stenting. Offer angioplasty for treating people with intermittent claudication. Imaging has confirmed that angioplasty is suitable for the person. Do not offer primary stent placement for treating people with intermittent claudication caused by aortoiliac disease. except complete occlusion or femoropopliteal disease. Considered primary stent placement for treating people with intermittent claudication caused by complete aortoiliac occlusion rather than stenosis. Use bare metal stents when stenting is used for treating people with intermittent claudication. Next. So these are the stents, the balloon expandable stent and the balloon. Can you please go to the next slide, Dr. Ravi? Yeah. Here, some videos for angioplasty and stenting we have done in our centers. Next slide, please. Deployment of stent.
There's some issues in playing the videos. Can you see the, like there's some issues in playing the videos. So can I go to the next slide?
Yeah, sure.
Yeah. Yeah, can you see the
and tibial arteries ballooning? Probably the video will not play. So next. So the bypass surgery and graft. We offer bypass surgery for treating people with severe lifestyle limiting intermittent claudication only when angioplasty has been unsuccessful or is unsuitable. And imaging has confirmed that bypass surgery infrainguinal bypass surgery. So these are from the NICE classification. Next slide, please. These are grafts, the PTFE graft and Dacron graft on the right side, that is aortoiliac graft. So what we do that aortobites commonly we use Dacron and the approach. Next, there is another picture and we can see that certain cut of infrarenal aorta, which there is a complete occlusion of both iliac arteries. Then aortofemoral bypass on the one side, maybe trans or retroperitoneal. Here we can use PTFE or Dacron grafts. Next. Now, for distal bypass, there's femoropopliteal bypass using reverse saphenous venous graft in the superficial femoral artery and communicating with SFA and the popliteal artery. Next slide. This is the case I did last month. So for we did endarterectomy and then femoropopliteal bypass. Next. In femorodistal bypass, there is infrapopliteal fempop bypass, maybe fem ATA or fem PTA bypass. Next. There are some extra anatomic bypass, that is avoiding the normal routes of the vessels. We do the femorofemoral crossover bypass. Sometimes we do the axillary bypass from axilla to the ilia. That is subclavian to common femoral artery. We use the PTFE graft or ring PTFE graft. Here we can see, next slide. Next slide, please. This is an atheroma that is it was taken out from the superficial femoral artery. The big length. Sometimes we do endarterectomy when there are the venous grafts are not available, or sometimes if we think that we can remove the plaques from the vessel. So endarterectomy of the common femoral artery. And in NICE classification, there was another point was management of critical limb ischemia revascularization. That is offer angioplasty or bypass surgery for treating people with critical limb ischemia who require revascularization, taking into account factors including comorbidities, pattern of disease, availability of a vein, patient preference, and do not offer primary stent placement for treating people with critical limb ischemia caused by aortoiliac disease, except complete occlusion of femoral disease. Consider primary stent placement for treating people with critical limb ischemia caused by complete aortoiliac occlusion rather than stenosis. Use bare metal stents when stenting is used for treating people with critical limb ischemia. Use an autologous vein whenever possible for people with critical limb ischemia having infrainguinal bypass surgery. Next. Management of critical limb ischemic pain. Paracetamol, laxatives, antiemetics for adverse effects. Refer people with critical limb ischemic pain with a specialist pain management service. With the followings, their pain is not adequately controlled and revascularization is inappropriate or impossible, or if ongoing high doses of opioids are required for pain control, pain persists after revascularization or amputation. In these cases, we can refer to a pain specialist, and do not offer chemical sympathectomy to people with critical limb ischemic pain, except in the context of a clinical trial. Then comes amputation. The major amputations, we always try to avoid any limb loss. Our target is for limb salvage, but sometimes we have to do that. Do not offer major disciplinary team. Next. These are the amputations. There are above knee amputation, below knee amputation. We have to do in several times because most of the patients do not come to us at proper time. That is treated by general physicians or surgeons. And ultimately, when they come, already a good portion of the limb has been gangrenous, and there is very less option for management. This is the options for amputation of the foot. Usually, for the toes, we do the toe amputation, metatarsal phalangeal joint disarticulation, transmetatarsal, and seams or chopper. Next. Next slide, please. It was a transmetatarsal amputation we did a few months back. Next. So what we practice? Sometimes we have to compromise and we do whatever is justifiable. Why? Because resources are available. What are the resources we have, open or endovascular? In a country like ours, in Nepal or in Bangladesh, in every portions, all the facilities are not available. So sometimes we have to compromise. And also the condition of the vein. There are issues of financial status of the patients, sometimes cannot afford the extent of ulcer or gangrene. So next slide, please. There are some last options when whenever the surgical management or endovascular is not possible, we do maximum medical management, prostaglandin therapy, usually have good result in below knee diseases. also stem cell therapy, and Dr. Robin was telling the platelet-rich plasma, like that. So this is all about the surgical management, and I wish long live Brotherhood of Bangladesh and Nepal. Thank you.
Yes, thank you very much, Dr. Santanu, for such a wonderful presentation, and with all the details in terms of surgical management of peripheral arterial disease. So before we go into discussion, I'd like to introduce my friend, my colleague, Dr. Sandeep Raj Pandey. So Dr. Sandeep Raj Pandey is a consultant vascular and endovascular specialist working in Kathmandu and in Annapurna Hospital as well as Norvik Hospital. And he's the first secretary of Vascular Society of Nepal and also SARC SPS. And he's also the first vice chairman of Youth International Union of Angiology. So let's welcome Dr. Sandeep Raj Pandey for his presentation on advances in peripheral vascular diseases management in Nepal.
Thank you, Dr. Robin. And firstly, I would like to congratulate on your 25th anniversary of Dhulikhel Hospital. And thanks for invitation. So I'll be speaking on advances we are doing in peripheral vascular disease at Nepal. And Dr. Uttam has initially told several things. And even Dr. Robin also mentioned what he's doing. So I'll be telling as a whole. So this is the Vascular Society of Nepal. No, we are like 8 members, and almost all are involved in treating the vascular diseases. And as a whole BSN team, we mainly treat peripheral arterial obstructive disease, deep vein thrombosis, varicose veins, vascular malformations, aneurysm, pseudoaneurysm, dissections, carotid disease, varicocele, pelvic congestion syndrome, fibroids, lymphatic disease, diabetic foot, etc. So PAOD patients mainly comes to us as manifestation of systematic atherosclerosis associated with high mortality due to severe stents, CV events, and they mainly present with claudication. And sometimes they come in late stages with even gangrene. So those patients, we directly go for amputations. But those who come to us early, we intervene them both by endovascular and open means. And these patients mainly have the sites of claudication in the aorta or iliac artery, femoral artery, or popliteal artery. And most of them also have below popliteal artery, mainly in the smokers and diabetics. So for diagnosis, like we are well equipped with vascular duplex. So we go for duplex scanning to see stenosis or there is thrombotic occlusion. And if we can't define well, then we go for advanced imaging, CT angio, MR angio, or conventional angiogram. So CT angiogram we mainly preferred most of the cases. You can see this, there is occlusion of iliac artery. And we do MR angiography for like renal failure patients where you can't give more dye. So treatment of PAOD mainly is to prevent ischemic events, to control risk factors, smoking cessation, blood sugar control, lipid management, and antiplatelet therapies. We start with clopidogrel or aspirin along with pentoxifylline or silistazole. So therapy based upon symptoms, we mainly for claudication, we do exercise therapy and pentoxicillin I told already. For critical limb ischemia, we do wound care, antibiotics, and revascularization, either endovascular or open surgery, mainly to promote the limb survival. So revascularization for aortoiliac disease, mainly we perform aortofemoral bypass, which is a primary patency of 5 years. So there is one case, so no fem-fem crossover for uniiliac CTO. No, she have occlusion of the iliac artery. So in this case, we did fem-fem crossover. And she have some gangrenous part in her toes and foot. So we debride them and amputated the 2 tips. We also do percutaneous intervention for these cases, which has a mortality of just 0.1%. Using these techniques with wire, balloon, and catheter and stents, we open the stenosis without open surgery by endovascular techniques. So the vessel is now open with the stents. So this is one case. No, here like iliac stenosis, where you can see the wires have crossed, and the last picture you can see it is revascularized with the iliac stent. Further, for FEMPOP diseases, mainly most preferred, and it's like bread and butter for vascular surgeon, FEMPOP bypass surgery. So in these cases, we do FEMPOP bypass surgery, and these have also less motility than aortoiliac interventions. So this is another case, a smoker, gentleman, chronic smoker. No, he have like occluded iliofemoral on right side. In this case, we performed FEM-FEM crossover and FEMPOP bypass. Crossover, then bypass. And he have also like gangrenous toes, which was amputated, and it healed well post-surgery. This is another case, but this has the distal occlusion. And for this, we have done distal bypass. So FEMPOP angioplasty, those who can afford, and it's like expensive than bypass surgery. And if they have like short segment lesions, so in these cases, we also perform angioplasty and stenting. So this one, femoral stenosis, SFA, and it has revascularized post angioplasty. Also, sometime after intervening these stenosis, they again come with in-stent restenosis. Then also we sometimes use drug-eluting balloons to open these vessels. For treatment of no option CTLI, my friend Augusta from Spain has starting deep vein arterialization, and he's doing several cases. But still there is no evidence to support the veins are still low quality. Maybe someday we also start in Nepal. Those who have like all vessels occluded, then they do the DVA, deep vein arterialization. So for acute leg ischemia, even in the acute leg ischemia, most of patients reach us at Rutherford 4 stage. Very few reach at early stage. And so always we have to see the 6 P's so that we start the treatment. And of course, the mainstay of treatment is embolectomy, taking out all the clots. If we still the muscles are viable, or we can further move with fasciotomy. If the limb is there, we can go for amputation. So new modalities for limb ischemia, thrombolysis. We can use TPA to thrombolize them, mainly for multi-level thrombus. Deep vein thrombosis, it is also very common in Nepal. So patient mainly comes with us swelling of leg, calf pain, red calf, and history. Most of them have like smoking, staying in cold weather, or some trekking, dehydration, long flight duration. So for this also we have gold standard angiosis by duplicate scan, where you can see the compressibility of vessel and blood flow, thrombus. So we plan treatment accordingly as per the treatment. So mainly for below femoral DVT, mainly we go for medical management with also NOACs and all we have available in our country. For proximal DVT, sometimes we try thrombolysis. So always need to treat DVT, otherwise the risk of P is very high in proximal DVT, where the clot detach and goes to lungs, pulmonary artery, and it leads to arterial hypertension, right side heart failure. So in this patient, we have to be aggressive in treating. So need to treat them to prevent the long-term complication of recurrence and post-thrombotic syndrome, which is very common in Nepal. Most of DVT patients are coming with venous leg ulcer. So management, it's even but general physicians also do this, heparin treatment immediately. Then now VK has been replaced in Nepal also. We treat them for renal failure patients. Otherwise, we are now using NOACs. Sometimes to prevent PE, we also place IBC filter, but it's rare in our scenario. We only do for very specific indication patients. So vitamin K, like so NOACs, we have in Nepal now dabigatran, rivaroxaban, widely available by several companies from Germany to Nepal companies. We have also products from Germany, Bayer and Boehringer, and there are many Nepalese companies producing. So we use these more because they have advantage of no lab monitoring, no dose adjustment, no drug-free interactions, no incidence of heparin-induced thrombocytopenia, rare drug-to-drug interactions, no bridging needed prior to invasive procedures. Sometimes we also perform open surgery for DVT, take out the thrombus, but this is not much common because it damages the valves, and there is again chance of recurrences. Better is the thrombolysis. We can do for proximal DVT with the TPA thrombolysis, and it gives good recanalization and prevents the post-thrombotic syndrome. So catheterectomy thrombolysis, we are available in Nepal, Actilize. even urokinase, we can perform this. These things we have not available, angiogelate, relatic and Strelis and all. Maybe soon we will have. So sometime like DVT, because of the anatomical abnormality, that nutcracker and May Thorner, we can also plan for stenting of the iliac veins. Varicose veins is very common in our country, and it is main work of private practitioner doctors. Patient mainly comes with varicose, but most of patients even come with ulcer and skin eczema. So for these also we have gold standard diagnosis of duplex. So treatment options, we have all options available in Nepal. So compression, sclero, surgery, endovenous ablation, non-thermal ablation, everything. But now, because do you like to introduce obese groins? No. So in this context, we are also using endovenous ablation in our country. No, we have both radio frequency and laser available in Nepal at many centers. So this is how we perform the endovenous ablation. It is a no incision, no cut technique. Patient can go home same day, walk same day. So non-thermal ablation, we have done some demo of Clarivane, MOCA, but we haven't started clinically yet because of allergy and certain factors. We are more doing ablation and sclerotherapy. So we also do many sclerotherapy for minor varicosities or from recurrences. So these are the results of the varicose surgery, before and after surgery, before and after, before and after, before and after, before and after, before and after. We are giving them good results. Sometimes we also treat varicose seals, mainly embolize, not open surgery. So it is the enlargement of the pambriform venous plexus in the scrotum, which leads to like decreased semen, sometimes testicular pain, maybe even late stage testicular torsion and infertility. So for this also we diagnose with Doppler, no, on gray scale, where you can see the plexus is more than 2 mm, we consider them varicose seal. And for those like open, we don't do much. It's more done by the open, general and neurosurgeons, but we do some embolization cases. No, it is less invasive and safe means, but it's expensive than the open surgery. So in these cases, we use catheters and coils and glues to embolize them. So this is one of internal splanchnitic vein on left side, which has a reflux of testicular vein. So it was embolized with the coil, no, we occluded. Then patient was significantly improved of all of those symptoms. So we mainly use glue, lipidol and foam rather than coils, because coils are very expensive in our part. We also treat a lot of vascular malformations. It's rare, but we are getting more. Maybe some patients who have not been treated for many years now, they are coming to us. So this is like hand venous malformation treated with sclerotherapy. This is also hand venous sclerotherapy and excision. This is a finger. This is also sclerorized. KT syndrome also coming in several cases. No, in these cases we do first sclero, then sometimes we also excise them with plastic surgeons to give good look, and it's more common in girls here. AVM, no, for like this was AVM in a young boy working in Korea. You can see the SFA feeders. So we just occluded them with the glue and lipidol, and he has good result. This is another case of very high flow AV fistula from inferior gluteal artery with large venous barracks of draining vein, where she went undergoing coil of embolization of feeding artery, followed by glue embolization through right femoral pressure. We also deployed the coil, and she also got good result. Oh, this is another case of young boy. He has like venous malformation just above the knee and left leg, left lower limb. And I did like 3 or 4 attempts of embolization. Then it was totally shrunk. Again, we did the CT angio and it was shrunk. There were like no feeders And then he was having painful because of this hard mass. Then it was taken out with the help of plastic surgeon just a week ago. So aneurysm, no, I have good experience of aneurysm abroad, but in my center I have less, but I'm very happy Professor Uttam is doing a lot of aortic surgery in Nepal. He's king of aorta. So for aneurysm, he also do open surgery. Even for thoracic aneurysm, we do TIVARS. Dr. Uttam is leading the path. And now he's also opening a hybrid OT where it will be more feasible to do the complex cases of aneurysms. The stent has been deployed. Now again, another limb will be deployed from this side. So for pseudoaneurysm, it is also very common in Nepal because of IV drug use and sometimes also because of the cardiac procedures. So in these cases, because most of them are infected, like for cardiac pseudoaneurysm, even we do the Doppler probe compression, but these IV drug infected, so we have to go for open ligation of the pseudoaneurysms. One case where stenting was done. Carotid also, no, I do more non-invasive, but intervention is, I think, more done by Dr. And then most of the neurosurgeons do at our country. This is a case of indirect tromy. Stenting, this is a case of indirect tromy. So I would like to summarize, dear faculties. So treatment of peripheral artery obstruction, even asymptomatic, should focus on risk factor modification of risk. Treatment of claudication should include exercise therapy, drug therapy, and selective use of revascularization, endovascular or open. Treatment of CLI warrants aggressive efforts at revascularization to reduce the risk of amputation. Endovascular options are more effective in reducing long-term morbidity after proximal DVT when compared to anticoagulation alone. Foam muscular therapy is a cheaper alternative to open surgery, and thermal ablation for primary venous insufficiency. Thermal ablation is superior to open surgery in terms of cosmetic, less pain, no incision, early mobilization, and same-day discharge. Thank you, everyone. I finished on time.
Yes, thank you, Dr. Sandeep. So thank you for a wonderful presentation and summarizing of different advances in peripheral vascular disease management in Nepal. So I'd like to open the floor for the discussion on the recent two presentations by Dr. Santanu and Dr. Sandeep. So if there are queries, please let us know the queries.
Dr. Robin, I just want to make a quick comment about those two talks. They were fantastic. I was just thinking about when we were talking about limited resources, not having trellis and angiojet and some of those things. I think everybody on this call, regardless of your geographic location, has limited resources. And in the US, our limited resource is probably not device or equipment, which we normally think about. It's common sense. And Dr. Florian and Dr. Anton can probably speak to this too. We have a lot of devices available, but it's great to see cases with good targets, with good veins, where good bypasses are done, and someone can do a great forefoot amputation and provide limb salvage. I'm showing cases of safaris, but I only do that. And you talk about deep venous arterialization, which I don't do a lot of. I don't really believe in the concept. That should be done as last ditch resorts. If somebody has a good target and a good vein, they should get a good traditional bypass and have limb salvage that way. And I think, we have to be cognizant of how we're using these new technologies to really make a difference. I have somebody in their 60s who had a popliteal occlusion, was a four-Bach claudicant, and over 6 months he underwent a safari, stenting in his TP trunk, thrombolysis, reintervention, and ended up with an ABI of 0.2. And I ultimately had to do a distal bypass to his post-tib with vein. That's what we should not be seeing when we just talk about, resources being used without common sense. So I think these are just great talks of how we can do good traditional vascular surgery in addition to really being thoughtful about new opportunities and new technology.
Yes, thank you, Dr. Mike. So
Yeah.
any comments by
if I make a comment, thank you, Dr. Mike. This was really opening a door to what I wanted to say. You're absolutely right, 100%, I would say. And you pointed out in your own talk, as well as Sandeep did right now, we don't treat pictures and we don't treat lab results. And it's very important to point out that PAD, peripheral arterial disease, is, as long as it's not critical, no real problem. And it's always, or treatment should always be performed according to the level or the degree of suffering, and not because we see some obliteration on the CT scan or we see some other things we think we can treat with new devices or however. So the conservative treatment in such patients is, I think, the most important thing we have to think of first before we start doing this safaris that you actually talked of, Mike. And especially for those who are not so much into the field of vascular surgery, and I think many of the ones who attend today are among those who are not really specialists yet, I just want to tell them, don't treat just for the sake of treating. Treat if the patient really has a problem, and when it's definitely no question, no discussion, if there's a critical ischemia, then we do have to do something. There's no discussion about that. But as long as it's not critical, we really have to make sure that we are doing good and not something bad for the patient.
Yes, thank you very much, Dr. Florian. Yeah, Dr. Dean, kindly continue.
But it's very important to recognize that a person has peripheral arterial disease, in that then you want to make sure you're treating their diabetes well, their hypertension, get them to stop smoking, exercise more, to try and prevent heart attacks, strokes, and progression of peripheral arterial disease. So it's important for GPs, paramedics, and so on to be able to recognize that a person has peripheral arterial disease, to treat it conservatively.
Dr. Ram, just a question for Dr. Shantanu and Dr. Sandeep. Great talks. Along Dean's points, how are the patients, you present some great cases, how are you screening for patients in your own practices? Because, you know, the most frustrating for me is somebody who comes in with bad 3-vessel tibial occlusion and bad pedal flow, and their first presenting symptom is gangrene. They never claudicated, and those are the people that really I find in my practice. They're delayed presentation. And then Dr. Shantanu, like you did, that guillotine TMA, those are hard to heal, right? Those take months and months to heal. And sometimes they fail in the long term. I've certainly had them go. How are you guys getting your patients? How is the screening done? Because that's a great point.
Thank you. In most cases, with the vascular surgeons, when you get a patient already, there are 2 amputations. When a patient in our region, most of the patients are the smokers. They have claudication, but not even notice or not even go to any doctor. And whenever they go, whenever there is any blackening of toes or any starting of any gangrene, they attend the local doctors and they do the amputation of toes. After that, there is non-healing ulcer. Then patient comes to the surgical specialist, and at a moment we get the patients. By this time, the gangrene has extended, or whenever we do the peripheral angiogram or whatever CT or MR angiogram, we see that most of the patients, they have only single run, maybe ATA or PTA, only one run. And sometimes the vessels are highly atherosclerotic, and the options are very less. Still, for balloony diseases, we try to do ballooning. We also do some balloons near the ankle, or we have tried few cases in the toe arteries, but the facilities are not available all the places, so the number of are less. But popliteal and tibial ballooning angioplasty, we do a lot of cases.
Dr. Mike wanted to ask us how do we screen these cases, no? So like maybe primary screening is ABI, but at my center there is no ABI. So I direct do Doppler because I myself too. So for all those cases, I just screen through vascular duplex ultrasound.
Screening, that is the basic things we do, the duplex, and step by step we do ABI, but mostly dependent on duplex, clinical examination, and then angiogram. And for follow-up, if patient comes for follow-up, then we do screening by duplex, most of cases.
Yes, thank you very much. So any more questions or comments?
Now it should be dinner break.
So before going into break, I could see Dr. Anton also with his video. So Dr. Anton, do you like to speak something? So Dr. Anton was the first vascular surgeon to help Dulikil Hospital to establish vascular services in Dulikil. So we are always obliged to him. So Dr. Anton, would you like to speak something? Can you unmute yourself? So Dr. Anton, please unmute yourself. Sorry, we could not hear you. And we have a raised hand by Dr. Kaushal Tiwari. So Dr. Kaushal Tiwari is also CTVS surgeon working in Maldives. And he has started many new cardiac surgical practices in Maldives. So we are fortunate.
They have also done the TAVI. He have done TAVI before us in Maldives.
Yeah, so we are very fortunate to have him in this symposium. So Dr. Kaushal Tiwari, please give us your comments.
Yeah, thank you, Dr. Robin. It's great to be attending this webinar and to listen very nice talks from our esteemed faculties, including Uttam Dai and Dr. Michael Malinovsky, Dr. Santanu, and Sandeep. Actually, just in the question and discussion session, I just wanted a few small, practical question to Dr. Santanu and Sandeep. What are your choice of vascular grafts in the peripheral artery disease? When do you choose autologous vein, and when do you go for grafts, I mean synthetic grafts, and what are the synthetic grafts choice you decide which grafts to be used, because there are so many different grafts are available. Yeah,
for for young patient, mainly we choose the saphenous graft, no? And for elderly, we use for synthetic. We have Dacron now is old. We have now EPTFE graft, expanded PTFE graft for old patient. And for young, we always give priority to saphenous.
Okay, and another thing, Dr. Sandeep, you was talking about the varicose vein and their treatments and several options available in Nepal and of course everywhere. Yeah. So my concern were we do see sometimes patients coming post endovascular ablation and foam therapy, the recurrence and the complications. How do you manage those? How do you manage those complications?
We re-intervene them. No, recurrence is like common thing in varicose. No, we can't tell 100% success. Maybe there is always recurrence for 5%. So we re-intervene them. Maybe they don't need again ablation because we have already ablated. They have some this residual varicosities. For we do foam sclerotherapy.
Okay, so you prefer, I mean, we recommend them to go for foam sclerotherapy better.
Yeah.
Or again with the endovascular.
Yeah, still maybe sometimes there is incomplete ablation, maybe due to not proper access or some very dilated veins. Then you have to also do re-ablation. But most recurrences are like minor varicose. We can treat with foam sclerotherapy.
Thank you. Yeah. Thank you.
Yeah, Dr. Kaushal, in Dulikil, we have also done some studies about what to do with these recurrent varicose veins. and we termed as a adjunct sclerotherapy. So there are two options, like during first ablation also we can give sclerosing agent, and another option is to do ablation in beginning and see for if there is any recurrence, and if there is only recurrence, then we give a second setting sclerotherapy. So physiologically and surgically, I think the second option is better, because we don't need to give sclerosing agent in all the varicose veins. But for patient, if we do in the same setting, it's convenient for the patient. But the best practice would be to do ablation in beginning, and only if there is major recurrence, we can do sclerotherapy in the second setting.
Okay, thank you. That's really makes sense.
Yeah. So any other queries or questions? So we have 2 minutes left before the dinner break, as mentioned by Dr. Sandeep. So any more questions? Any questions and comments by Dr. Yanto, all the way from Indonesia?
Maybe later on, Robin. Thank you.
Okay. And we have also many new vascular surgeons in the participants list. I could see Dr. Rajat Pradhan, who is also a CTVS surgeon working in Bhaktapur. So any questions, any comments by Dr. Rajat, if you are listening?
Yes, thank you, Dr. Robin. It is a wonderful session and very knowledgeable for young vascular surgeons like us. So recently I have joined Guest Hospital. So now I'm doing some vascular surgeries started. Probably will be also starting on cardiac surgeries also. So off the topic, I want to discuss a case, probably a few minutes for me, please. So recently I attended a patient who had a self-diagnosed DVT. He self-diagnosed himself. He's an IT guy. And yes, he has a history of IV drug abuse. And he started himself on warfarin, 5 mg BD for around like 10 to 12 days. And then he had some gum bleeding. And then he went to the hospital. So he had DVT from a common iliac vein to the distal tibial vein. And he stopped warfarin for 3 days and came to me. So when I saw, he had PT of 16 minutes. So INR was not calculated. So I admitted him just for monitoring. He had no severe acute bleeding or anything. So I would like to hear like management on this patient from respective seniors and experienced faculties. He had stopped warfarin 3 days back already. So what could be like, shall I put him on vitamin K or anything else, or just watch and wait? Because still after 2 days of admission, he had PT of 10 minutes, which was earlier 2 days back, it was 16 minutes. So what should I do? And his DVT, his symptoms are very less now. He has no pain and the swelling has also decreased. So can someone please light me the management on this patient, please?
Yeah, thank you, Rajat, for this case, very interesting case. So I'd like to request the faculties, like maybe Dr. Florian can comment.
As long as he doesn't have any bleeding complications, I think I would just see and wait and do the labs again, maybe tomorrow or the day after. And also I would adjust compression therapy. And if the INR is into a reasonable level, then I think I would let him go. And I would definitely follow him up in a close management, but he's IT staff, you said, so it should be easy to follow him up. Is that right?
Yeah, I have started compression stocking surely and the ambulation also, but it's been 3 days, but it's been already 6 days that he has left warfarin, but still PT is high. So are there any other drugs that we could give him, or just watch and wait for that?
But what's his liver function is okay? Did you?
Yes, Other liver functions are okay, but prothrombin is still high.
And what's the INR like?
INR, they couldn't calculate.
Why is that? Because they don't have the...
Because the PT is very high.
More than 10 minutes, right?
More than 10 minutes.
Yeah.
So it must be something like 5 or 6 or something like that, approximately.
Yeah.
Well, again, I think I would test it again and see if maybe it was the miscalculation.
Well, I have cross-checked in other labs also.
Okay. Dean, what would you say? Mike, any idea?
See, if I think if the patient does not have any bleeding complications, and as long as he's stable and no bleeding is there, and as you said that PT is decreasing from 16 to 10 minutes now, so probably this the best way is to wait and see and monitor closely so that he does not develop any bleeding complications. And I think this will go down probably because he was taking self without any control, that warfarin, high dose of warfarin. I think that's why his prothrombin time has increased so high, and better to wait for some time and then see if it will come down, then again restart from the low dose warfarin and go adjust according to the INR, the warfarin dose, or you can go you can shift the patient to other anticoagulant like Novak and other things like rivaroxaban and other drugs. You can, according to the availability, you can change to that. But as long as there is no bleeding, I would suggest not to do anything, just to monitor.
Okay, thank you very much.
Thank
you, Dr. Robin.
Yeah, thank you for very nice suggestions and plans for this patient. So as a quick note, like to Dr. Rajat, like now NOACs are also very readily available in many parts of Nepal. So although this case, that warfarin was started by the patient himself, so might be we need to switch to NOAC once these issues are better.
Yeah, and, once the PT INR gets to normal range, right?
Yeah. Yes. Yeah, and also to all the participants, most of the vascular surgeons know this thing, but it's a quick important thing to know. Like warfarin, we used for decades and still being used. It was discovered in Wisconsin. It's the place where Dr. Dean and Dr. Mike are from. And Dr. Dean took me to the lab where warfarin was discovered. There's a very big research lab now. So we are very fortunate to have this drug for for decades. So it was a very good place to visit. So I'd like to thank Dr. Dean for taking me there. Thank you. Yeah, now I think we should go for like 15 minutes break. So we can call this as a dinner break in Nepal, maybe like a breakfast break in USA, and some other breaks in Bangladesh, Indonesia, and Maldives maybe. So we will rejoin in exactly 15 minutes. So that is 8:20 in Nepali time. And we'll continue with the second session of hemodialysis access session. So I'd like to suggest not to log out from this Zoom. So just we can stop our video and mute ourselves. So in 15 minutes, let's come back again, and we'll continue with another great session with presentations by Dr. Navin, Dr. Florian, Dr. Dean, Dr. Satish, and Dr. Yanto. So thank you very much for this first session, wonderful session. So we'll continue in exactly 15 minutes. Thank you.